Welcome back to Scalpel and Scribble, your trusted guide to simplifying complex medical concepts. In today's session, we'll be talking about acute pericarditis, its presentation, investigations, management, and prognosis. Let's dive in. Pericarditis is simply the inflammation of the pericardium, the protective sac around the heart. Patients often start with a prodrome, things like fever, muscle aches, or general malaise. Then comes the hallmark symptom, chest pain. This pain is typically sharp, pleuritic, retrosternal, and what's unique is that it improves when the patient sits up and leans forward. Many patients also complain of shortness of breath. On clinical examination, the most classic finding is a pericardial friction rub. In some cases, muffled or distant heart sounds may point toward a pericardial effusion. When it comes to investigations, routine labs like CBC, renal panel, electrolytes, and ESR are usually done. Cardiac enzymes may be ordered if myocarditis or myocardial infarction is suspected. If bacterial pericarditis is a possibility, blood cultures are crucial. On ECG, the early stage often shows widespread ST elevation and PR depression across multiple leads, while later on you might see diffuse T-wave inversions. Echocardiography is a key tool here, since about 60% of patients show some pericardial diffusion. The causes are broad. It can be idiopathic or viral, but also infectious like bacterial, fungal, or protozoal. It may occur with cancers like breast or lung carcinoma, connective tissue diseases such as lupus, after cardiac surgery, following trauma, with metabolic issues like uremia or hypothyroidism, or even as a reaction to medications such as hydralazine or procainamide. Management begins with one critical step. Always assess for tamponade. Look for raised neck veins, pulsus paradoxus, and hypotension. Most uncomplicated cases are treated with NSAIDs for pain and inflammation, and sometimes corticosteroids are used if symptoms persist. Anticoagulants are generally avoided. Treatment becomes specific when the cause is identified. Bacterial cases need IV antibiotics. Tuberculosis pericarditis requires anti-TB drugs. Malignant cases are managed with chemotherapy, and uremic pericarditis improves with dialysis. Follow-up is all about monitoring. Patients should be assessed regularly for new or worsening effusion or signs of tamponade. Around 60% of patients develop some pericardial effusion, but less than 10% go on to develop tamponade or constrictive pericarditis. Prognosis depends heavily on the underlying cause. Idiopathic and viral cases usually resolve well, while TB and malignant causes carry a more serious outlook. And that wraps up our overview of acute pericarditis. If you found this explanation useful, don't forget to like this video, share it with your friends, and subscribe for more concise, high-yield medical content. Until next time, keep scribbling your way to success.